Good afternoon. I'm Dr. Bobby Tullos. I'm a pulmonologist and critical care specialist here at Memorial Hospital in Gulfport. Today we're doing a streaming event where we try our best to answer the questions you may have related to COVID-19. I do have a set list of questions that we're going to answer, but the fun part about this is the unknown. What are you going to ask? There's a lot of rhetoric out there, there's a lot of opinions, and there's a lot of people who just have different things that they want to say. There's doctors and nurses, etc., and the list goes on. And this is all posted on social media. And while I'm not here to address all of those or to give you my personal opinion, I will try my best to answer from my perspective what we see in both the acute care setting of treating COVID-19 to the outpatient setting for those who are fortunate to survive and are in recovery. So, as we wait for your questions to come in, we'll start at least with some of the prepared questions.
All right, Dr. Tullos, what role does a pulmonologist play in helping a patient with COVID-19?
So generally, if a patient is admitted to the hospital with acute COVID-19, that means that their disease has progressed enough to require some level of oxygen. And this disease really affects the lungs, primarily at first. And our hospitalists do an excellent job in maintaining a good treatment plan for those patients, but for some, as their disease burden gets worse and the degree of oxygen that they need increases, pulmonologists or lung specialists will get called, like myself or my colleagues, to help figure out the best mode of oxygen they may need, either a type of ventilator or high flow type oxygen, a high concentration of oxygen, to see what we can best do. We also will continue to follow those patients. Unfortunately, if they get worse and require transfer to the intensive care unit, or they may require intubation or full life support with a breathing tube down their throat. And so that's really in the acute setting where a pulmonologist plays the biggest role. Perfect.
All right, what are some long-term common issues that you are seeing from those who are recovering from COVID-19?
That's a great question. So, you know, our clinic will see folks who come in mainly with the biggest complaint is shortness of breath. So COVID, if you are greatly affected by this disease, and for some even not admitted to the hospital, it will greatly affect your lungs and your lung health. And while you may not require oxygen, you may still have this sensation of what we call dyspnea or shortness of breath with exertion, that just you can't get back to normal. You've done all the right things, you've gone through therapy, you've restarted your home activities, but you just don't feel back to normal. And we're seeing this, at least in my clinic, for the next several months after the acute infection, and for some folks, 8 to 12 months after the initial disease, that they just don't feel back to normal. And oftentimes, while we do a very thorough workup to see if there is anything else that can be associated with this, we're finding that for some people, this is their new normal. And the virus itself has just caused that degree of damage to where they can't get back to their life as they were before the disease.
And would you tell us a little bit about what would have a patient go on a ventilator and what that process looks like to put someone on a ventilator?
So I'll try to answer that question the best as I can, because in the past several weeks, as this has gotten more of a burden within the world and what we see here in Mississippi, the process of going on a ventilator. Gosh, what we see here now are those patients. We look at really two big parameters. Can I supply them with the amount of oxygen they need without a ventilator, or are their bodies just to the point that they are completely exhausted and they can't keep up trying to do that work of breathing? For some patients, just imagine sitting in bed, being in the best shape of your life, and you've been essentially running sprints, but you're sitting still. You can't do that forever. You run sprints on a regular time out on the road, and you're going to get tired, and you're going to quit, and you're going to rest. But your body is at a fight or flight, trying to survive experience, and it can't rest. And you can't do this forever. And so as patients either reach the point where you cannot provide them with the amount of oxygen they need, or they're becoming extremely fatigued, then we'll have to proceed with intubation, being placed on an invasive ventilator a breathing tube down the throat. We will sedate folks, but oftentimes for our team, the hardest part is having those last moments with them, because for so many of us, time and time again, we are the last faces that some of these patients will see. We know that and they know that. We're the last people that they pray with. We're some of the last hands that they'll remember holding until they get asleep on these medications, and we give them the best effort that we could possibly do to get them through this virus. And that's the process of becoming on a ventilator.
So what are your recommendations to keep you and your family safe during the pandemic?
This is probably going to be commented on by many about opinions or facts or what have you. But I can tell you from experience, I don't have, after just answering that question about putting patient on a ventilator, I cannot recall in these last several weeks putting a patient on a ventilator that received a vaccine. I'm a huge proponent, and many people have talked about, now I've seen you on the commercial, don't hesitate, vaccinate. Yeah, it seems kind of cheesy, right? But that is the number one thing that someone can do. I'm sure the commentary is going to be fraught with a ton of questions or comments about the vaccine, but to be honest, I received it as soon as it could come out. I'm doing okay. There have been so many people who have received the vaccine. Over almost 3 billion people worldwide have received this vaccine. And again, not just here, not just in Mississippi, but all throughout the world, those who are greatly burdened by this disease and still succumbing to the most worst parts of it are those who have not been vaccinated. So the best thing that you can do for yourself is get a vaccine.
And can you catch the same variant more than once? And if so, is the second time worse?
So for some patients, yes, they will, most likely if you've had COVID once, or you've been with just the vaccine as your sole protection, you've not been infected with it before, yeah, you can get infected with the disease again. Your body's immune system will do the best it can to generate that prepared immune response after you get a vaccine, so the next time you see the virus again, you'll be teed up and ready to go. And you may still get infected with a virus. You may have been infected with the initial variant of COVID-19, and then now you may contract the Delta variant. But still your biggest protection is, can you prepare that immune system for its next encounter for it? I was in the military for 22 years and retired. Soldiers do their very best to train all the time, so when they do see that enemy, they'll be ready to engage, and that's why we're so successful in the things that we do. Your body's immune system is the same way. It sees a little bit of this vaccine, it prepares, and it's ready to go to war the next time it sees the real deal. Sorry, I can get a little passionate about this.
And should I still go to the ER and seek treatment for other problems with everything going on with COVID?
That must be a generated question.
No, that's live from the audience.
That's what I mean. Like, yeah. Somebody asked that question. If you have a true emergency, most sure, and you need emergency level of care, yes, you need to go to the emergency room. The hardest part that I think people have seen and talked about, at least with my colleagues, is it's not just about COVID. Our hospitals are inundated, yes, heavily with COVID, and it's affecting wait times, about getting triaged or treated or being admitted to the hospital, but we're doing the very best that we can, and if you have a true emergency, then this is where you need to be. That's why they call it an emergency department or emergency room. So if you have an emergency, yes, that's where you should go.
Now, why are patients that are vaccinated getting COVID-19?
So I think for a lot of people, they think this is an end-all. I get vaccinated and I won't get sick. And then they're kind of frustrated when they do. And I'll go back to what I said earlier. The vaccine is to give your body's immune system that alert. Hey, when you see this again, you don't need to wait several days to build up an immune response. You've already seen it. you are ready to go. You are primed and to generate that immune response. And so yes, you may still get infected. You may get infected by a different variant. We see this oftentimes in flu season. We're vaccinated for 2 different types of the flu, but guess what? There are different subsets of this virus that are still able to get you infected, and it will still give you a level of support. And so yes, the vaccine is there to help your body be ready for when it sees it again. So you may still get sick.
Now, are you seeing a significant difference in those who are vaccinated and unvaccinated?
Yeah, tremendous. And this is no political ploy. You know, that's just the fact remains is that I don't recall in the past 3 weeks being asked to see a patient in the hospital, and when I ask them, have you been vaccinated, that their answer is yes. So that tells you something, that there may be people admitted to the hospital. I agree with that, that they came to the hospital, they're sick, they were admitted, and they received a vaccine. And I told you earlier in this interview that I get called as a lung specialist or a critical care specialist when that patient gets severely ill and requiring much more life support options. And so I've not seen anybody that's been vaccinated that's required my assistance or that of my colleagues that I can recall. So that tells me that they don't get as sick. And so, yeah, hopefully that answered your question.
It does. So could smoking and or vaping make you more susceptible to severe COVID-19 symptoms?
I think that question, you know, anytime that you put an insult onto your lungs, you know, no one sits in a house fire because the smoke burns and you would die, right? But people smoke cigarettes and it's just in small doses and it's not as catastrophic right there at first. Maybe a harder analogy to understand, but anytime that you inhale that smoke, not only does it affect the lining of the lungs, you have impaired secretions. Your body's ability to mobilize those secretions and cough them up are impaired. It affects the distal airways for your body's ability to really breathe effectively. I mean, that's why we have diseases like COPD and emphysema. And so most certainly if you have continue to smoke or vape, and you're priming yourself to potentially have more complications from COVID.
So we're going to go back to what it's like to work with the patients. Could you tell us a little bit more what it's like to care for a COVID-19 patient, and what does the recovery look like for someone who is having severe respiratory issues?
Okay, I'll try to run from the kind of the start to finish. And so when I get involved, someone's requiring a significant amount of oxygen. We look to see what we can do to make sure they don't have complications. Some patients have developed a spontaneous lung collapse, for example, or people will develop pulmonary emboli, which is a blood clot within the lungs as it relates to infection with COVID-19. And so we try to get them through that initial part. And if they segue to the next portion to where they go into fulminant breathing failure to require the ventilator, then we do what we know works. We probably have read a lot now in the past 2 years about proning or placing people on their stomachs. So we place them on their stomach, then we place them on their back. We give them medicines. We make sure that they have nutrition, and all that gets through there. And if they survive that point to where we can look at taking them off the ventilator, unfortunately for so many, they are so incredibly weak. We're talking 2, 3, 4 weeks on life support. They have not moved except for when we move them, that they are really extremely weak. And so oftentimes the next step in terms of recovery is we do what's called a tracheostomy tube. So we remove this breathing tube here, and now it's in their neck. And because not just are their arms and legs muscles, those muscles weak, but their diaphragm is weak. Their swallowing muscles are weak, and oftentimes they can't swallow without concern for aspiration or food going down into the lungs, and so they would then require having a feeding tube placed in their stomach. That's probably the first step in terms of being liberated, per se, from the intensive care unit. But that's not where your journey stops. You then are no longer sedated, hopefully. You're continuing to recover. Your body's now in that next phase, and we hope at some point within the next several weeks that your muscles start to regain that strength. You're able to start swallowing on your own, and you're able to protect yourself, and we can give you less oxygen and less support, and we're able to take this tracheostomy tube out. We're able to remove your PEG tube, but still the journey's just getting going. You've not walked. You've not stood up on your own. You've not been able to help manage your activities of daily living. And so you're looking at a several week process of recovery to get to that point. And oftentimes, even though it's been several weeks or months since the acute infection or being in the hospital, that the patients that I see in my clinic, they're young still, they're old still. They're different levels of success. A lot of times they're coming in wheelchairs, still on oxygen, but they're giving me little bits of success. Today I was actually able to go to the bathroom on my own. And that is probably hard for somebody in their 40s to say. I was able to walk across the room and for the first time not wear oxygen and get to the bathroom and go on my own without assistance. So that's kind of what we see from the start to finish for those who are fortunate to survive the disease.
And we're going to jump back to the vaccine real quick.
Okay.
How can I be sure that the vaccine is safe?
You know, I mentioned earlier that I've been in the military, or was for 20-something years. And I should be glowing with the amount of vaccines they require us to get. I mean, it is quite a volume of vaccines. And so, but with any of them, whether there's anthrax or smallpox or anything else we received, and now the COVID vaccine, yeah, I had the same level of trepidation too. I mean, this appears to be new technology. And for those who have taken time to go through this in detail, your body generates messenger RNA. That's why you're alive. That's how you make protein. So the messenger RNA is not new. It's been there since inception. But now to take synthetic messenger RNA to generate a virus for this, that research started in the early 90s. And so for quite a long time, and it took a while to catch traction, and we needed the technology to be able to figure out how to use what our body already generates, messenger RNA, and to create a synthetic version, which can then be used to partner with our immune system to generate an immune response. And so when we think about some of the other vaccines that we've had in the past, do we have the same preservatives in there that we have? That stuff has been kind of excluded out of this. And so I can't take it away. You give almost 3 billion vaccines worldwide. Are you going to see a side effect? Yes. But I can tell you what our hospitals don't have currently, at least here that I'm aware of. Patients admitted on life support based on side effects of a vaccine. So I think that it's safe. I'm not having conversations with people who are vaccinated and talking about putting them on life support. And it's not there. Is it something that you should talk with your physician about and not the local experts on social media? I think so. Your health is in my best interest. Why else would I be doing this and putting myself on social media to talk about it? I think it's something that can protect you and should be very well considered. And again, I don't have a dog in the hunt in terms of a political thing about these vaccines. It's not anything that I care about. What I care about is the health of my community and the health of my family and your family. So that's why I would encourage people to consider doing it.
So what are the most common illnesses or comorbidities that you're seeing come into the hospital with COVID-19?
Obesity. And guess what Mississippi ranks very high in? Obesity. The associated things that you see with obesity: high blood pressure, diabetes, kidney disease for those who are on dialysis. If you've got one component of organ failure, congestive heart failure, COPD with lung failure, kidney failure, anything that predisposes you. Sorry, there's an overhead announcement that you may hear. But anything that predisposes you with an existing organ failure, then you contract COVID. I mean, that just sets you back. But the patients that we're seeing who are my age, who are not doing well with this, the overwhelming health characteristic that we're seeing is obesity. Are all patients who are that sick obese? Absolutely not. But that is probably seen more times than not, is the kind of predisposing thing if you don't have medical problems, what you're seeing. So that's what we're seeing at least.
And what's the recovery rate look like for someone who's made it into the hospital with COVID-19?
If you go on a ventilator, I mean, the most up-to-date statistics, I couldn't give those to you to be precise. I know at one point it was around, if you go on a ventilator and then you subsequently develop another organ failure besides your lungs, I mean, the risk of, I mean, the likelihood of surviving this is, you know, easily, I would say, less than 15%. And I don't know the exact statistics now, but this was at least 8 to 12 months ago. And that's to survive. Now, that's to get out of the hospital to survive, right? Go back and listen to the other part of the video where we're talking about just because you've survived, how's that affected your life? Most likely, for some people, forever. That you may not ever get back to being the person that you were before. Some of the cognitive or memory impairments that happen to some people, they don't ever come back. The breathing issues, they never return back to normal. So it's just not like recovering from a disease and that's it. You just go back to work. You got it. You lived through it. You know, I was one of the lucky. No, it's not like that at all. And so, you know, if you develop that profound of a disease and you have to be intubated or put on life support, I will worry about you surviving the moment that we push those medicines to put that tube in. And I mean, that's the honest facts.
And have you seen any different trends with the Delta variant in a younger population?
Yeah. So, well, you know, last year I think a lot of what we saw was the novel COVID-19, and it was really affecting more of our older population. Our younger population seemed to be doing okay with it, but the Delta variant, as we have said time and again, it's more contagious. It seems to be slightly more virulent. It causes worse disease symptoms, and the people in our hospital last year were probably our grandparents' age, at least my age, my grandparents' age. But the folks that we're seeing now, the average age is in their 50s. Unfortunately, even as of this weekend, you know, after someone didn't survive the illness, I had the unfortunate conversation to speak with a new single dad who now has to figure out how he's going to take care of his kids. And that was probably the most heart-wrenching conversation I've ever had to have. And so we're seeing a much younger population out there. We are unfortunately having parents in their late 40s with kids who may be in their 20s or 30s not surviving this. These people haven't even had a chance to live so far, and it's not affecting everybody. I understand that. But for those that it does and they're here, man, I just worry about them surviving. And I think it's a lot of what we see, to answer your question, with the Delta variant.
So what happens to your lungs when you get COVID-19?
That's a great question. I wish that we had probably every answer to that, because then that would hopefully give us a degree of how to fix it. There is an overwhelming, I think, inflammatory response. This is why we use one of our treatments of steroids to really suppress that inflammatory response. You know, we think about, in terms of medicine, a term called ARDS, or ARDS, acute respiratory distress syndrome, to where essentially your body's ability to exchange oxygen into the body, to the bloodstream, is just greatly impaired. And that may be on the front end. On the tail end, for some of our patients, it's almost like the lungs lost its elasticity, or it's like that sponge. You have a good brand new sponge, healthy looking sponge. You squeeze it, the water comes out and it goes back into its normal shape, ready to soak up water again. And then you have that old dried out sponge that you need to toss, but you never do. And you squeeze it when it's dry, and it just kind of crinkles and stays in that kind of squeezed position. That's kind of what a fibrotic lung is like. It can still probably do a little something, but it's not really great. So our gas exchange is impaired. It's hard to breathe out that carbon dioxide. It's hard to exchange and get that oxygen into our bodies. And so for those who have greatly affected lungs by the disease, they have, in some instances, developed that chronic fibrotic form, to where they just will never get reversed and go back to normal, and that's just kind of their state at that point.
Now, what do you wish more people knew about this virus?
I think we've answered a lot of those questions. So what I wish you knew more about it. Well, it's not going anywhere. It is deadly for those that it can affect. We have a vaccine for it. It seems to be working. We don't have a cure. For example, I don't have a medicine I can give you, a tablet to give you as an outpatient. You get the flu, and everybody runs and gets Tamiflu, that trademark, or Zofluza, the other one. I don't have a medicine to give you, and so I can't cure it. It's going to probably be around for a while until we can come together and do something about it. Probably for those in the United States, what I wish you knew about it, it's real. I think that we take for granted how severe this is. We, around the country, have places having expired vaccines where other places in the world are begging for their first dose. And we won't get our first dose here, and we have a plethora of it. And so I think it's just real, and I think it's something not to be taken lightly, and I think that the whole rhetoric behind political motivation, I think, just should be tossed out the window and really think about public health and what you could do for those who live with you or around you.
So thank you for sharing your experience with us today, Dr. Tullos. Do you have any final thoughts you'd like to share?
No, I'm pretty much an open book when it comes to COVID-19. I try not to engage too much on social media. There are lots of opinions there. Even I can be prone to maybe address a comment or two on there, but we in healthcare are tired. We are at unprecedented levels of providing the best care possible. We would ask that you would find some type of comfort in seeking out our opinion, and not that of just the internet, to utilize the experiences that we have. If you're not sure, ask us. You think about Pfizer and the drug they came out with Viagra. You trust your doctor for that one, but you don't want to trust Pfizer for the vaccine. And so, that wasn't even intended to be used for what it was used for, but people used it. People say, I don't know what's in it, and I don't know what's in it, so I don't want to put it in my body. I don't know what's in a loaded tea or any of these other drinks. I don't know what's in a McNugget, and a lot of people eat those, and they don't have to think about it at all. And so, just try to extend a little bit of trust in those who are working every day. We are tired of crying at the bedside. I have said with patients their last prayer that they will ever hear. I have had to talk to families who are now single parents. My staff works tirelessly and hours upon hours upon hours, and one would hope that when they're done with their 12-hour shift that workday stops. But the emotional toll that they come home with doesn't stop. I imagine that for many of them, they feel detached. If you try to engage with them, they may not be there. Their spouses may recognize that too when they get home. They're home, but they're not home. We are trying to do our best. We would ask that you partner with us and reconsider getting a vaccination, because as much as we would love to see you and we would love to take care of you and do the best that we can for you, we would not like to see you at the same time. We have something that works. Please consider it. If you're not sure on what you should do, ask us. Because I don't know of any physician that I've talked to when I discuss with them the vaccine that their first reply to me is some political rant. It's not. We talk the facts. What have you seen that works? What have you seen that not work? And so there are tons of educated people out there who have spent their entire lives not just being nurses, not being respiratory therapists, to be the experts in what they do. Just like I go to see an expert who's going to build my house, I don't question him. He is the expert in what he does to build that house. And this is the experts of what we do to try our very best, reading the most up-to-date literature every chance we get to give you the most informed information. And probably the last thing I'll say about it is I would encourage those who are thinking about using the drug ivermectin that I'll tell you what we just got a kind of report on today. The Mississippi Department of Health has been inundated with phone calls regarding toxic levels or symptoms of people taking ivermectin at home, either from a farm livestock or from whatever. But toxicity is now being generated in some people who are choosing to take the drug ivermectin on their own. The literature doesn't support it being used. People will argue and bring up another paper that may show it's for it, but I think it's more so like the hydroxychloroquine of last year. This drug can cause problems. Please do not be a statistic. I would hate for your family to be calling on your behalf the hotline for the toxicology. So anyway, that got serious real good at the moment. Our office is available if you are recovering from COVID and you're not sure what to do. Do I need to see a lung specialist or not? If you're still, ask your doctor. I don't require, and neither do my staff require a referral. As COVID becomes more difficult within the community, we will certainly have to augment what we do in the inpatient versus outpatient, and we may be a little bit restricted there, but we're not shutting down. We're still wanting to take care of you. We want to do the best that we can. If you feel like you need to see an expert in lung diseases, then don't hesitate to give us a call.